Hi, everybody. Good evening, good morning, good afternoon, wherever you are. Welcome to the IACH Journal Club. This is our traditional journal club every 15 days as part of the educational activities of the International Academy for Clinical Hematology. I'm Mohamad Mohty from the Sorbonne University and Saint Antoine Hospital in Paris. And it is always my pleasure to moderate this very popular and unique journal club. The IACH Journal Club is supported through a generous unrestricted educational grant from Takeda Oncology. And for today's journal club, the steering committee selected this paper recently published in the Journal of Clinical Oncology, and it is entitled Third-Party BK Virus-Specific Cytotoxic T Lymphocyte Therapy for Hemorrhagic Cystitis Following Allotransplantation by Dr. Amanda Olson and colleagues from the MD Anderson Cancer Center in Houston in the United States. And you can see here the summary of this paper, and I'm not convinced that I need to spend a lot of time to convince the transplant community, for instance, that hemorrhagic cystitis is becoming a matter of concern, especially since the advent of high-dose cyclophosphamide for prevention of graft versus host disease, not only in the haploidentical transplant setting, but in general as a backbone for GBHD prophylaxis. And unfortunately, some patients are going to experience some severe hemorrhagic cystitis, which is a source of morbidity, toxicity, but also sometimes, unfortunately, mortality. And we know that treatment options are quite limited in this situation. And this is really why this paper was very attractive, because the authors actually developed a specific BK virus specific cytotoxic T lymphocyte, a third party, and they have tested this cellular therapy product in healthy donors, and they have in healthy donors, but also, of course, they were generated from healthy donors, and they were tested in patient, and they have shown some impressive results with little side effects. And actually, you can see here the patient response in this cohort at different time points after BK virus CTL infusion. And this is really a very high rate of CR, which while we usually struggle with the hemorrhagic cystitis in these patients. And when you look to the viral response in these patients, again, I believe these curves, these figures are quite self-explanatory. So really a very promising approach, and we in the transplant community are eagerly waiting for these products. So for the purpose of this journal club, it is my great pleasure to welcome Dr. Amanda Olson, who is the first author of this paper. So we are very happy having you with us, Dr. Olson. You are an associate professor at MD Anderson Cancer Center in Houston, and your focus is on cellular therapy, especially when it comes to viruses in the broader field of transplantation. And the other panelist tonight is Dr. Annalisa Ruggeri, who is also a top expert in the field of transplantation from the San Rafael Institute in Milan, in Italy. And actually, Dr. Ruggeri has published a few papers on this complication of hemorrhagic cystitis after transplant. So Amanda, Annalisa, welcome, and thank you for joining us. I know it's a busy clinic day So we're very grateful for both of you, to both of you, for supporting the IACH Journal Club. Welcome. Okay, so now I think we'll start this journal club. My first question is going to be directed to Dr. Ruggeri. So Annalisa, can you give our audience a brief summary or reminder about hemorrhagic cystitis, especially the risk factor, the diagnosis, and the current management guidelines, I would say?
Good afternoon, everybody. And thank you, Mohamad and the IACH for this great invitation to this excellent journal club. And thank you, Amanda, for joining us. This is a really an important and critical aspects of the complication, the early complication of transplantation. And as you kindly remember, it's been more and more reported in the recent era with the great change of the transplantation management with the expanding use of non-HLA matched donor and also the use of post-transplant cyclophosphamide. So we have to consider that the seroprevalence of the BK virus is extremely high worldwide, reaching almost 80% across the population. And the infection usually occurs during the infancy and then being latent, especially in the epithelial cell of the renal-urinary tract for a long time. Typically, the incidence of hemorrhagic cystitis has been reported in solid organ transplant recipient, as well in patients exposed to high-dose cyclophosphamide. And usually there are, according to the temporal occurrence of the hemorrhagic cystitis, two main differences in the classification as an early onset, which is more likely related to the toxicity, direct toxicity of the therapy into the urothelium versus the late onset after 1 week after therapy due to the BK virus reactivation. And what is important to consider is that since the use and the change in the transplant management, these incidents changing was more and more reported, and up to date we know that almost 60 to 70% of patients may experience hemorrhagic cystitis, especially during the period of aplasia. So this was really intriguing, especially during the early experience with post-transplant cyclophosphamide, and I am grateful of the work we have done in Sant Antoine Hospital while we were seeing our patients with this very difficult to treat hemorrhagic cystitis and not being able to identify unique risk factor, because of course this is a multifactorial event with a different action triggering the viral reactivation and then the clinical onset. There are several degrees of disease which came from dysuria and stranguria up to clotting and severe hematuria. And among the main risk factors, we have to consider those related to the use of the conditioning regimen, so the more toxic regimen and the use of post-transplantation cyclophosphamide is one of the direct actor implicated with the damage of the urothelium. Then the type of donor, especially having a different degrees of incidence of the event from going through the matched to the mismatched donor. But as you previously mentioned, with the common use of post-transplant cyclophosphamide, also in the setting of sibling donor and matched unrelated and mismatched unrelated donor, this is no more such critically related to the use of haploidentical donor. Then the delayed immune reconstitution and the occurrence of GBHD, as well the concomitant immunosuppression, are also some important factor impacting on the possibility to have viral reactivation, as well as other concomitant virus. And it's important to consider that the management is usually done after a clinical, which is really typical, and then the detection of the BK virus into the urine test through the PCR with the viral load, a very high viral load, which is associated also to the clinical aspect. Unfortunately, there is no clear identified factor for the treatment, and the management is done according to the different experience, or whether the use of cidofovir as when possible for the toxicity related to the treatment is clearly reserved to the most severe cases. As well, supportive therapy with hydration and also other supportive with IV immunoglobulin is really controversial and is not yet clearly standardized. And what is important also to consider is that this event, which is clearly an infectious disease, is associated with morbidity and also cost in the high hospitalization rate for those patients who often need support with transfusion like platelet and other supportive care. So having a treatment is really an unmet need, and I really thank Amanda for
we'll talk about the treatment. Thank you, Annalisa, for very nice comprehensive summary. I'd like to remind our audience that you can send your questions, your suggestions, your comments using the Q&A or the chat box, and I will of course distribute and share this with the panelists. So Amanda, congratulations for this really lovely work. Can you just give us an overview? How did you generate these cells, and what are the characteristics of this product?
Sure. Thank you so much for inviting me to participate in this prestigious event today. I appreciate the inclusion. The CTLs are generated from peripheral blood mononuclear cells of the normal healthy donors. We have a bank of these donors, and they're actually typically sibling donors, so the HLA typing is already done. We take the peripheral blood mononuclear cells and expose it to the peptimix, which comprises the 5 immunodominant antigens of BK. So VP1, VP2, VP3, small t, and large t. We then also add that to cytokines, IL-7, IL-15, and then we co-culture for about 2 weeks. At the end of the co-culture, we have cells that, when presented with BK proteins and antigens, produce interleukin and interferon in response to that. So we've shown the data in our publication.
Excellent, thank you. So this is really amazing. And Annalisa, when you saw these results from this paper, knowing all what you know about this complication, what was your reaction? Was it like the wow effect, or what was your feeling?
Absolutely, and yes, the impression after reading this excellent work was very positive, given the high incidence of response and also the possibility of performing further infusion when in case of need. And what was also really interesting, and I would like to ask Amanda some detail on it, is like I saw that the median time for infusion was very early. However, some patients had also late infusion, and those patients having received a late infusion were treated late at a later stage, or was at an hemorrhagic cystitis occurring later, approximately over 6 months after transplantation, if I'm not wrong.
Yes, absolutely. You're right about that. So the hemorrhagic cystitis, so people come to us at various stages. So it's sort of a mix of both. So we have had patients who have received treatments elsewhere, cidofovir, for instance, and can't tolerate because renal insufficiency complications, or they're just not responsive to other sort of supportive care measures. So we have people who are refractory to those and then are referred into our institution. That's definitely happened. We also have patients with complications like graft versus host disease or cord blood or haploidentical transplant, who then go on to have prolonged immunodeficiency and develop BK at these later stages. So that's sort of why the infusions are at later stages for some. I would say that's probably the majority of the later ones are those, but we do have a handful of patients that have been referred in and have been refractory for months.
Excellent. So, but then Amanda, how do these results compare to sort of a standard of care, supportive care, and maybe antiviral therapy, assuming that antiviral therapy works?
Yes, so we allowed for all concomitants. So sort of, we allowed for cidofovir, we allowed for supportive care. So patients were basically, in the interest of patient care, because we know that this is such a devastating complication after transplant, we allowed for patients to receive all of those things. And so this was a phase 2 study, non-randomized. So we did compare with historical controls, and compared with historical controls who received, some of whom received cidofovir, some of whom received other supportive measures, including hyperbaric oxygen therapy, nephrostomy tubes, et cetera. Patients had many fewer transfusions, so a median of 6 in our treated patients versus 20 in the historical controls, which is quite different. And if you look at the characteristics of the historical controls versus the treated patients, the historical controls were a bit sicker, so they have higher grade hemorrhagic cystitis than the treated patients. So it's not as if we sort of picked a population that was easier to compare with or easier to treat. I'm sorry, our patients were actually sicker than the historical controls. That's what I meant. And so we didn't have a population that was easier to treat. In fact, our population was more sick than the historical controls.
Okay, so we have a question here from the audience about, these are third party, but you have used the closest matching. So what do you mean by close matching? Can you please clarify this concept?
Sure, because the response to BK is CD4 dominant, we base matching on HLA class 2. So that's our priority. So if you'll notice, the median sort of HLA match, I think, is on table 1, but we had responses even in patients who have a 1 of 6 match, as long as it's one of the class 2 antigens. We require that they match at least one of the class 2. And the response rates were actually not dependent on the degree of HLA match. So it seems that the number of cells generated certainly matters, but the degree of match, at least in our analysis of the limited number of patients that we have, was not found to be significant.
Excellent. So Annalisa, having in mind that these are third party, not fully HLA match, would you be worried about the risk of graft versus host disease and so on?
Yes, Absolutely. This was something that while reading the paper was really coming in mind, because of course the use of third-party donor not closely matched in early post-transplant period may expose the patients to a further risk of GBHD, and which of course will further increase the need of immunosuppression and then clearly impact on the characteristics of the patient. But while reading to your results, I was very impressed by the safety profile and also the low risk of GBHD that you have been reported. And actually, no, you didn't experience any severe grade 3 to 4 GBHD. And among those patients who had chronic GBHD, my question was if those cases were under immunosuppression, stopped immunosuppression before the BK-CTL infusion.
We required that patients be on less than 0.5 milligrams per kilogram of steroids due to the potentially damaging effect of steroids on the CTLs. And so patients had been on steroids. The steroid dose was lowered such that we could meet that minimum criteria and infuse CTLs. And to be honest, I did expect a pre and post systemic steroid sort of significance. And it didn't come out in the statistics, so it wasn't found to be statistically significant. Just sort of my gestalt from taking care of the patients was that seemed to matter, but the statistics say otherwise, at least in this sample.
So Amanda, we have a few questions that I will try to summarize and group together about. Are there any contraindications in patients who should not receive these CTLs?
Yeah, so we limited patients to patients with not active graft versus host disease. So they really had to have the graft versus host disease under control due to the potential of development of graft versus host disease in patients who are immune primed for that. So we refused to give in those cases. And then another exclusion criteria was uncontrolled infection. First pass of any cells that we give is through the lung. And so in particular with patients who had pneumonia or were on high dose oxygen, et cetera, we're very careful not to give in those cases should a patient have an adverse response. We did not have any of those adverse responses, but we're very aware of sort of excluding patients who had other uncontrolled infection. And we actually had quite a few with uncontrolled infection. And then do you want me to answer the other questions? I saw a few, but would you like to ask, or do you want me?
I'll come to them.
You'll prime me. Okay.
I'll structure
Perfect.
them. So, Annalisa, assuming tomorrow you have these cells available immediately, would you be willing to use them frontline for any patient who develop hemorrhagic cystitis? Any level of severity, or is this like a sort of a second line salvage treatment? What are your views on this?
Assuming immediately available with also we will discuss probably later about the also the cost of this kind of cell therapy. Indeed, in ideal world, having this tool for treatment, absolutely, this would be very welcome in our clinical experience. However, as you said, I rarely think this would be a first-line treatment. Also, depending on the clinical characteristics of the patient and the severity. In a case of severe clinical scenario with also need of supportive care and high burden of transfusion, for sure, this would be an important tool to propose to the patients. Not in the first as first line treatment, also because of the risk of further complication, with maybe associated, of course, your trial show very good safety profile. Indeed, the risk of GBH, as we have discussed, is something really worry. So I guess it would be for the second line treatment in case of very severe disease.
So Amanda, in your routine practice today, outside the protocol, are you using the CTLs?
Yeah, so we're still, so we sort of did we're doing an extension of the protocol, so it's up to, I think, 300 patients potentially that we can treat now. And these CTLs are really first line, so we've changed our practice at MD Anderson such that we use these cells immediately. I think, you know, even the other sort of ancillary members of the team, the nurses on the floor will sort of prompt somebody, oh, have you emailed Amanda to see if we have a line for this patient? Or so it's become sort of so routine that everybody knows about it and knows that this is kind of our practice here. We run into it because of the calcineurin inhibitor issue. We run into a lot of problems with cidofovir. And so I think at least the culture here is to sort of shy away from that. We don't include patients who have grade 1 per Betty criteria hemorrhagic cystitis, because it's sort of not worth it to give. We think that they'll self-resolve. These patients are more likely to sort of immune reconstitute and clear the virus on their own. But if it does progress, certainly to the point of needing admission for IV hydration and pain medication, et cetera, then we'll definitely start searching for a line earlier rather than later.
Okay, so here actually we do have a couple of questions that go together, in my opinion, to you, Amanda. One from Dr. Ravi Shah about the correlation between immune recovery in these patients and actually the response. And the other question from Dr. Youngwoo Jun is about, well, if they are effective in the curative approach, can we use them in a sort of a preventive or prophylactic approach? Is this something you have in mind?
Yeah, so these are great questions. So in our other use of these cells is for JC virus, John Cunningham associated PML, which is a totally different paper and journal club, hopefully in the future. But these, so we did look at immune reconstitution in the paper that we published in the New England Journal in 2018. In terms of response, immune reconstitution response. For this paper, there were 59 patients, so it's too difficult to sort of calculate all that out. But we did not find, at least sort of in the rough brush that we did statistically, did not find a difference in the response rates based on immune reconstitution versus not. So I think that the patients who are going to immune reconstitute are, again, the ones that we sort of exclude, that have mild, that have had a sibling donor transplant, that have not received post-Cy, or any of the other sort of bigger risk factors that we discussed. And then to answer the other question about giving preemptively, so Dr. Ballard at Children's National is doing several studies now, and we're collaborating with them on a few of those, in giving the cells. So these are in cord blood transplant recipients, mostly children, although we've done some adults as well. Excellent safety profile. You take a fraction of the cord and immune expand to several different viruses. This was previously called the CHEERS protocol, but has been sort of expanded to include other viruses, including BK. And these cells are given preemptively before development of the virus. And as you know, with cord blood transplants, viral infection is a big problem, particularly early on.
So that brings me actually to another question we've been hearing for several years, including some plenary communications at big congresses, about the multivirus or polyvirus CTLs. And I think there was a lot of excitement in the field about like having a sort of a magic cell that is able to fight all kind of viruses you would see in patients. So why not developing such approach, and where do we stand there? I believe, Dr. Ruggeri and Annalisa, you would be very excited of having this magic cell.
So, yeah, sorry, go ahead.
No, let's go.
Our colleagues across the street at Baylor, who we collaborate with very closely, just because of proximity and because they're wonderful. Helen Heslop and Annalisa's group has published extensively sort of on the multivirus CTLs. You can see in figure 1 that we did characterize, so we did a multivirus product, and most of because the innate T cells are more CMV trophic, most of those cells will be reacted to CMV rather than BK. So in patients with severe hemorrhagic cystitis, it makes sense to treat with a single virus approach. At least in our opinion, these cells are definitely more potent to BK versus the multivirus CTLs.
Wonderful. Your thoughts, Annalisa?
Yeah, and I was very impressed while reading this aspect and the main CMV-driven response in case of multivirus. So I agree that having a specific product for easily to manage for such kind of patients would be absolutely really welcome. And I have another question, if I may. Which is related to the other aspects related to the persistence of the CTL, because there was a peak over 28 days and then persistent up to 3 months. But do you experience any like faster reactivation or clinical relapse of the hemorrhagic cystitis later on?
So the response was sustained in all the patients who achieved response on the therapy. So in this population, we did not experience sort of relapse after the CTLs cleared. And I think it to a huge degree depends on the degree of immunosuppression in the patient, right? So in some patients, we can detect these cells for up to 250 days, and sort of the persistence of the cells, and beautiful work that was done by Dr. Katie Rasvani's lab, who is sort of the developer of this and my mentor, showed that you can HLA type the donor versus recipient, track these cells in those patients in the CNS when you're treating PML for up to 250 days, and it triggers an immune response. So there's T helper cells that also get activated. So I think it triggers the immune cascade such that if you're going to be somebody who's going to respond, then the response is durable.
Okay, so one last word, Amanda, what's next? Because we're reaching the end of this journal club. What are the next steps?
Yes, absolutely. So coming up, Dr. May Daher here has a really exciting product. One of the big limitations of these cells is that you can't give them with patients who are taking a ton of steroids, right? So 0.5 mg/kg or more, which is typically the patients who develop horrible hemorrhagic cystitis. So what she's doing in the lab, along with Katie Rasvani, is CRISPR gene editing and knocking out the steroid. They're basically steroid-resistant gene, such that you can be on huge amounts of steroids and they won't be damaging to the CTL product. This is very exciting for the future. The trial should be open in the next 3 months, and we anticipate being able to treat a much larger population of patients, because it's always sort of a clinical conundrum when you have the patients who have graft versus host disease can't taper immunosuppression. You really don't want to stimulate them with more CTLs, and so to have the CRISPR gene edited steroid knockout is going to be amazing.
Well, wonderful. Thank you very much, Annalisa. Thank you very much, Amanda. That was really a fascinating discussion. Definitely, this is a huge progress. Congratulations, and we're very grateful to your group, to Katie is the group, Dr. Rizvani, who's, by the way, a very good friend. Hi, Katie, if you're watching us. This was really a fantastic discussion. And I hope everybody has enjoyed it. Thank you again for your loyalty to the IACH Journal Club. And wherever you are, please stay safe and keep well, and see you in 15 days for another Journal Club. Thank you very much. Have a good day, have a good night, have a good evening, or whatever. Thank you. Take care.
Thank you.
Thank you.